Welcome to the elbow, ulnar, radius fracture and dislocation lecture. The objectives for this lecture are the following. You should be able to recognize and diagnose upper limb fractures specifically related to the ulnar, radius and around the elbow. Discuss the best management, either operative or non-operative, for the individual fractures, and then discuss the different surgical techniques for these patients. Also to assess the upper limb for possible nerve or vascular injuries sustained during upper limb fractures. Elbow dislocations. In adults, the elbow is the second most common dislocated joint next to the shoulder. In the pediatric population, the elbow is the most common dislocated joint. Dislocation in a posterior direction is the most common, where the olecranon moves posterior in relation to the distal humerus, and that is called a posterior dislocation. The X-ray views needed for diagnosis are an AP, a lateral, an oblique view, and a CT scan is also helpful to differentiate the various segments and to plan the operation. As acute care, closed reduction and immobilization in a splint is advised, and for operative management, if there's associated fractures or bony fragments in the joint, plates and screws can be used, K-wires. As part of the assessment, it is important to consider the following points. Pain on a VAS scale or numeric pain rating scale, looking at swelling. This is also visible on X-ray, but also in your physical exam, to ensure that the compartments around the forearm are soft. If there's any deformity, notable deformity, if there's any open wounds present, it's very important to note this, as this will indicate the management of the fracture. Or if there's any open fractures where the skin is punctured, an open reduction, internal fixation is normally the outcome, and the doctors will do an exploration. This will also determine if there is any neurological fallout in the upper limb, when they will decide to explore and look at the nerve or not, or leave that. So even if it's a small open wound in the skin, it's very important to do a thorough assessment. Look at the neurovascular status, meaning is there circulation going to the fingers and the hand. You can assess this by looking at capillary refill, testing capillary refill, less than 2 to 3 seconds of blood returning to the nail bed after squeezing it. The Allen's test, where you occlude the radial and the ulnar artery, ask the patient to pump their fist till the skin is white, blanches, and then you release one part. Let's say, for instance, the radial artery side, and then look for that blood refill into the hand. Give the hand a few seconds rest and repeat again, and then leave the ulnar side. Also palpating the radial and the ulnar arteries on the wrist, on the volar surface of the wrist. Then also looking at temperature. Palpate and see what is the temperature of the injured hand compared to the non-injured hand. Then also look at the color. there any discoloration? It will give you an indication of a lack of blood flow to the fingers or individual fingers. Then do a thorough sensory exam and also a motor exam. Remember, if there is a query of tendon injuries, to respect the area. The laceration will accompany the fracture, and the laceration will be on the volar aspect of the hand if it is a flexor tendon, or the dorsal aspect of the hand or forearm for extensor injuries. And remember, then you don't want to passively move that finger or actively, as the tendon pieces will separate and retract. Very important in these type of fractures around the elbow is, like I said, to look at the compartment pressures. They need to be soft compartments, or else it is a medical emergency and need immediate care in the ER. Also be on the lookout for associated wrist and shoulder injuries. Remember, your X-ray principles have the joint above and below, and also do a thorough subjective and objective exam. Due to the complication of stiffness around the elbow joint, it is important to start early active range of motion within the first week, even from day 3 to 5 post relocation of a posterior elbow dislocation. Remember, your doctor or your surgeon will also guide you and tell you what the protocol is, or you will know already what the protocol in your unit is. But early active from respecting pain is very important. The terrible triad. What is it? It is a combination of 3 different injuries around the elbow. Firstly, a posterior elbow dislocation, accompanied with a radius head fracture, as well as a coronoid tip fracture, where the olecranon moves posteriorly and the coronoid tip is fractured. This is a complicated injury to manage and often requires operative management. Depending on the radius head and coronoid tip fracture displacement. Radius head fractures accounts for 20% of all elbow fractures. Remember to assess for any associated injuries to the wrist, shoulder, and even look for an elbow dislocation when you see a radius head fracture. Also, assess the patient for nerve injury, as the posterior interosseous nerve wraps around the radius head. The classification used is the Mason-Johnston's classification, dividing the fracture into 4 different types, as you can see at the bottom right of the slide. In type 1, one fragment is present with no displacement. Type 2, one fragment displaced. Type 3, multiple fragments. Type 4, multiple fragments and displaced. When doing an assessment for a suspected radius head fracture, there will be tenderness over the lateral elbow. Pronation and supination active movements will be painful as the ulna and the radius rotates. The X-ray views necessary for diagnosis is an AP, a lateral radiocapitellar view, and that is a lateral view with the tube angled 45% towards the shoulder to improve the radial head visualization without the coronoid in its way. A CT will be asked when the fragments are displaced for operative planning and also to assess the joint congruency. The physiotherapy management. When the fracture is minimally displaced and there is good range of motion of the elbow, a brief period of immobilization for 1 week is required, then early active range of motion respecting pain. If there is significant displacement and a mechanical block to range of motion, that means that's a complex injury pattern. Open reduction, internal fixation with plates and screws, and at worst the radial head will be replaced. Fragment excision is rare as the radius head requires its shape to rotate with forearm pronation and supination. So possibly a splint post-operative, a Dinah splint, and that is an elbow splint, so static or dynamic progressive splinting, but only for a short period. Early active ROM within 1 week. Give 3 to 5 days of rest just after the operation for the patient to settle, as well as the soft tissue around the elbow, and then commence your early active ROM. Moving to the forearm fractures, and now looking at the MONTEGGIA fracture. What is a MONTEGGIA fracture pattern? This involves a proximal third of the ulnar fracture with disruption of the proximal radial ulnar joint, where you can see in the images the radius is dislocated. It's very common in adults, and the mechanism of injury is a direct blow to the ulna or a fall. You get an extension type or a flexion type. The extension type is more common and occurs in 90% of MONTEGGIA fracture patients. An anterior MONTEGGIA with the extension type, as you can see in the image on the bottom left, where the radius is dislocated volarly, and then the posterior MONTEGGIA, the flexion type, where the radius head is dislocated posteriorly or dorsally, and this occurs in 10% of patients presenting with this type of fracture. The management are of using plates and screws, and first to reduce the radius head. The elbow is then immobilized in above elbow back slab, plaster of Paris, for a short period of time before active range of motion is commenced according to doctor protocols. Here is an X-ray example of a MONTEGGIA fracture pattern. And now a GALEAZZI fracture is a fracture of the distal shaft of the radius with dislocation or involvement of the distal radio-ulnar joint, the drudge. Or the inferior radio-ulnar joint. The management also of the radius with plates and screws. The ulna should be relocated spontaneously once the radius is fixed. May use pop or pressure bandage for a short period of time before commencing your physiotherapy. Contraindications and precautions. Post-operatively is no forced passive movement, although you can start using some passives but no forced movements, respecting pain always. Because of the drudge joint involvement, be careful of pro and supination for the first 2 to 3 weeks for that ligament and the joint to rest and repair. In this illustration, you can clearly see the difference between a MONTEGGIA and a GALEAZZI fracture.